You have been using the wrong measuring stick. If you're measuring your hip problem based on how much it hurts on any given day, you're making decisions with a signal that has almost no relationship to how serious the damage actually is. I've seen this play out the wrong way thousands of times, and it's one of the most damaging misunderstandings in hip care. I'm an orthopedic surgeon who specializes in hip preservation. I've performed over 2,000 hip preservation surgeries, and I've seen more than 15,000 hip patients in my career. What I'm about to tell you is something I wish I could say in every waiting room, because the patient who's in the most pain isn't always the patient who needs the most urgent treatment. In this video, I'm going to show you what pain level actually tells you about your hip and what it doesn't tell you, and how to know whether you're in the group that needs to move faster than your pain is signaling, and what four indicators actually determine severity. So here's point number one. Pain is a nervous system signal, not a damage report. For most of our lives, we think that if it hurts a lot, something serious must be happening. If it's manageable, things can't be that bad. This belief isn't irrational. In fact, in most acute situations, pain is a reasonable proxy for damage. A sprained ankle hurts more than a bruise. A fracture hurts more than a sprain. Clinicians reinforce it too. We ask patients to rate their pain on a scale of 1 to 10. We track it over time, and we use it to assess progress. Pain has been treated as the primary measurement tool in patient care for decades. So naturally, it makes sense that patients would follow that lead. Here's the thing though. In hip pathology, the relationship between how much something hurts and how much structural damage is present is actually remarkably weak. I've operated on patients with alarming pain levels whose joints, when I got inside, were in far better condition than I expected. I've also operated on patients who described their pain as a manageable 4 out of 10, sometimes been going on for years. And then we found cartilage damage that was so extensive, far more advanced than their pain had ever suggested. And the patients I'm most concerned about aren't the ones with the strongest pain. They're the ones who have been managing something tolerable while the joint is actually being damaged. So pain is a signal. It's not a diagnosis. It tells you something is off, but it doesn't tell you how bad things actually are. And the clinical consequence of this mindset can be quite serious, because patients who hurt a lot assume they must need surgery urgently, and patients who hurt a little assume they're fine. Both groups are making decisions on incomplete information, and one of those groups is quietly running out of time. So once you understand that pain score and damage severity are measuring different things, you stop tracking the wrong number, and you start asking better questions at every appointment. Which brings us to the specific tissue that makes this problem so serious and why it can be failing without ever telling you. So here's point number two. Cartilage doesn't send warning signals before it's gone. Most patients assume that if something significant were happening inside their joint, they would feel it. The body would tell them. Pain would escalate. Something would give them a clear sign that it was time to act. This assumption comes from how we experience most injuries. Muscle tears hurt acutely. Ligament sprains are hard to miss. Fractures are impossible to ignore. The intuition that damage produces proportional warning has been reinforced by most of the injuries people have actually experienced. But cartilage has no nerve supply. None. It doesn't generate pain directly. So the damage just piles up in that cartilaginous tissue that can't tell you about it. And by the time the cartilage damage produces the kind of symptoms that make someone finally book an appointment, a meaningful amount of damage has often already occurred. A structural problem like femoral acetabular impingement, FAI, creates a mechanical situation where the bones are repeatedly smashing into the soft tissue inside the joint with what could be normal movement. So every repetition adds a small piece of damage. That process doesn't track with pain. The joint is getting wrecked on a different timeline than the nervous system is reporting. You're tracking your pain, but the damage isn't waiting for the pain to catch up. Here's the thing about cartilage. Cartilage doesn't regenerate. Once it's gone, it's gone. And at that point, we're no longer talking about preservation. We're talking about replacement. And the group that shows this most clearly isn't the patient you'd expect. I've worked with high-level athletes, people with massive pain tolerance who've trained themselves to tell the difference between discomfort they can push through and pain that means something is wrong. Athletes are good at that assessment for muscle fatigue and acute injury, but they're terrible at it in the context of progressive joint damage. Because progressive joint damage doesn't always feel progressive, it just continues. That same pattern then also plays out in patients who are not athletes. Someone manages a hip problem for a year or two because it never gets bad enough to feel urgent. When they come in, though, the cartilage tells a different story than the symptom history does. The pain was a 4 out of 10 the whole time, but the joint damage wasn't. Therefore, duration and function become the signals that are worth tracking, not your pain score. How long has this been present? And what have you stopped because of it? These two questions tell me far more than numbers on a scale. That leads directly to how you can check right now whether you're in the group that has more time or less than you think. If this is already changing the way you're thinking about your hip, subscribe before we go further. I put out videos every week on the specific clinical questions that determine outcomes in hip care. And this is exactly the kind of information that doesn't show up in a standard appointment. Point number 3. Are you in the group that has more time or less time than you think? Here's a way to check your assumptions right now. Go through these questions honestly. Has your hip pain been present, even at a manageable level, for more than 6 months? Number 2, have you changed what you do because of your hip, even if the pain itself feels tolerable? Number 3, have you stopped a sport, avoided stairs, modified how you get in and out of a car, or given something up entirely that you used to do without even thinking about it? Are you someone who moves through discomfort regularly, an athlete, or even an active person who might not notice a 4 or 5 out of 10 because it's just background noise? Has anyone ever looked at the structure of your hip, the bone shape, the labrum, the cartilage, or have you only been assessed based on how much it hurts? If you've answered yes to the above 3 or 4 questions and you haven't had a proper structural assessment, you are in the group I'm most concerned about because your pain may be doing a terrible job representing what's actually happening in your joint. And manageable pain with functional loss and long duration behind it is a different clinical picture than manageable pain that just started last week. So if pain score isn't the indicator, what actually is? And here's the framework that I use with every patient. Point number 4. These 4 things actually determine hip severity. The answer this video has been building towards is this. Severity in hip pathology is determined by 4 things, and pain isn't one of them. Number 1, the first is cartilage condition. Cartilage doesn't regenerate. We wish it could. The degree of cartilage damage visible on imaging and confirmed during surgery is the most important severity indicator for me. And it essentially has no required relationship to pain score. Number 2, the second is the underlying structural problem around your hip. What's the impingement morphology? How significant is the cam lesion or pincer lesion? Is there hip instability involved? These all matter because it tells me whether, with your continued activity, your joint is continuing to injure itself. A structural problem that generates repeated mechanical damage with every step is progressing whether you feel the pain or not, and whether the pain is signaling it or not. The third is loss of function. What has this patient stopped doing because of their hip? What have you stopped doing? Because over time, your hip clearly just stopped cooperating. When patients start listing the things that they no longer do, that list tells me more about severity than any number on a pain scale. The fourth is duration. How long has this been present? Longer duration, even with tolerable pain, usually means more cumulative structural damage. Time isn't neutral in hip pathology. The joint has been absorbing the mechanical consequences of whatever structural problem's been present for the entire length of symptoms. So stop making decisions based on whether your pain feels manageable. Manageable pain and manageable damage aren't the same thing. So I want you to start tracking what you can no longer do and how long that's been true. That's the severity signal worth bringing to every appointment. And here's exactly what to do with that information before your next visit. Point number 5. What to bring to your next appointment instead of a pain score. Most patients walk into a hip evaluation having tracked one thing, how much it hurts. What I need from you is a different kind of map. Think of it like a weather report versus a topographic survey. Pain is today's weather, how things feel right now. What I need is the terrain. What's changed, what's been lost, how long the ground has been shifting underneath you. One tells me about this moment, the other tells me about the trend. And in hip care, that trend determines urgency. And so when you walk in with this information, instead of a pain score, you change the quality of the entire conversation. You give your provider something they can actually act on. So here's what to do tonight before your next appointment. Write down every activity you modified or stopped in the last 12 months because of your hip. Be specific, not I'm less active, but I stopped running in October. I avoid sitting for more than 40 minutes. I no longer cross my legs. I no longer work out. That's your functional loss map, and that's more informative than any pain rating that you can write down for me. Write down when you first noticed something was off, even if it was minor. Calculate the actual duration in days, weeks, or months and write it down explicitly to share with your provider. Identify one specific activity that used to be easy but is now painful, limited, or gone entirely. This becomes your functional benchmark, that concrete thing that you and your provider can use to measure whether treatment is working. Ask your provider one direct question. Based on what you can see, are we managing my symptoms or are we addressing the structural source of damage? That distinction tells you whether the pain is aimed at how you feel or what's actually happening in the joint. In conclusion, your pain's a starting point. It's what makes you pay attention. It's what gets you into clinic. It's what tells you something has changed. That part of its job is legitimate. But once you're past that starting point, pain is a poor guide. The patients I'm most concerned about aren't always the ones in the most pain. They're often the ones who've been managing something tolerable longer than they realize, while the joint is telling a different story on imaging. So really, what determines severity is cartilage condition, structural problems around the hip joint, your functional loss, and the duration of your symptoms. So if you reorient your self-assessment around those four things, you'll have far more of an accurate picture of where you actually stand. And so will the clinician you're working with. In conclusion, so if you want to understand why imaging alone isn't enough to guide treatment and what the right diagnostic sequence actually looks like, watch this video below next. It covers what imaging misses, when a diagnostic injection changes everything, and how the questions I ask before any treatment decision protect patients from going in the wrong direction. That video is linked below.